next 20 minutes, we are going to discuss what is the role of anesthesiologist in cath lab. If you ask me, what is the role of anesthesiologist in cath lab in one word, I will say that the role is like a wicket keeper. He has to always, nowadays, the season of IPL is going on, everybody is watching the matches. A wicketkeeper has to continuously on the field for maybe for 20 hours or 50 hours, whatever as per the match format. He has to watchful for each and every ball. There is no scope of complacent. He has to at the same time actively motivate the team member. And if anything is going wrong or anything, he has to keep continuous watch on everything, and he has to coordinate those immediate actions, maybe by captain or maybe by bowler. Very vital role wicketkeeper plays during the field, and which may not be noticed by everyone, but his role is very, very vital. The importance of this topic is that nowadays there is sudden increase in the number of cath lab everywhere. When we started practice of cardiac anesthesia, there were hardly 1 or 2 cath labs in the city. But now there are more than 20 cath labs in the city. We are doing more than 400 interventional procedures per month. And these procedures are variety of procedures at various ages. Maybe we are giving anesthesia to one neonate for atrial septostomy, or next case might be a TAVI or 90-year-old geriatric patient who requires a transcatheter aortic valve replacement. And anesthesiologist has to present for all these cases. So requirement of anesthesiologist is there. And unfortunately, those who are trained in cardiac anesthesia or who have a proper training in cardiac, their number is very less. So all anesthesiologist has to attend these calls in a cath lab. For that, this topic is very, very important. Now, as an anesthesiologist, what are the challenges you face when you are working in a cath lab setup? Basically, many times anesthesiologist is called when there is an emergency problem in a routine cases. Case angioplasty or angiography is going on their routine way, but suddenly there occurs a ventricular fibrillation, there occurs a hypotension, and suddenly anesthesiologist called. Or in certain cases, electively anesthesiologist called for in the cath lab. We have to may at times give monitored anesthesia care, we have to give sedation, or even we have to give general anesthesia to these patients. There are too much variety of procedures. Maybe we are doing coiling, interventional radiologist, or peripheral angioplasty, or maybe a aortic stenting, or coarctation of aorta, or maybe it is a simple plasty or cardiac cath for congenital. So the procedure is, there are variety of procedure for which we have to remain present. And invariably, there is unstable hemodynamics. We are facing this situation in a cath lab with a very unstable hemodynamics. Even the person with whom we are working, they are not familiar with the OT setup. They are not familiar with the anesthesia part. So they are from a medical background. So they are not used to work in a OT setup, or what are our problem, they don't know. Even the staff is also unfamiliar. So it's a very, very challenging for anesthesiologists to do work in a cath lab setup. And all this we have to handle in a compromised remote setup. And that is the biggest challenge anesthesiologist has to face when he is working in a cath lab. As you know, anesthesia is a roller coaster journey of challenges. When you are doing day-to-day cases also, you face a lot of challenges. And especially when you are working at a remote location, this number of challenges are increased many folds. But we need to keep ourselves cool, updated and prepared, so that to ensure the safety of our patient. Our motto or our main target, or to whom we give service, is our patient, and his or her safety is the priority for which we all work. How, as an anesthesiologist, I should tackle these cases in a cath lab? The first and best thing what I always feel is the checklist. which is one of the most high power productivity tool ever discovered as per Brian Tracy, and that we all must use while even entering into the cath lab. Whenever you go to cath lab, always check whether there is all airway preparations are there. Are you able to take patient's airway control as soon as or as and when required? Is there availability of oxygen, suction, emergency drugs? Certain drugs you have to keep loaded like atropine, adrenaline, phenylephrine, mepenteramine. You must check defibrillator whether it is checked or not, because many times when it is required, unfortunately it is not charged. Then patent IV access. This might seems to be a very simple point, but when you suddenly give atropine in the cath lab and you try to give atropine and you find that the IV is not properly placed. So these are the very small things, but these are very, very important things when you went for such cases in a cath lab. Short PAC is always desirable. So any under conditions of complexity, not only checklist help, but they are required for the success. As we compare our field with air field or aeroplane field, and before they start or before they fly their aeroplane, they always complete the checklist. And similarly, whenever you went to give anesthesia, you must rigorously follow this checklist. Invariably, we get a call for these patients at last moment. It's not like that. It is, even though it is planned, we may not be involved or we may not have been called for a pre-anesthesia checkup. So short pre-anesthesia checkup is mandatory, and it is invariably done on table or just before the procedure. Just ask for presence of comorbidity, allergy, patient is diabetic, since how long is NBM, what was his last sugar, all these small checks we must do. Whether patient has received morning dose of drugs, if patient is on plastic, whether he has received antiplatelets in adequate dosage, that we must confirm. You must see the baseline vitals because they are very important. Suppose one patient has got a baseline heart rate of 52, if you don't see and directly you see in a cath lab, there are chances that you will mislead with this. So baseline vitals are very, very important, and just go quickly through the lab and echo report. Echo report is very, very vital for us to know, manage these patients, whether to give fluids to these patients, how to manage this patient, whether there is a presence of diastolic displacement, all so many things echo tells us. I'm not going to in details of that, but you must quickly see the echo report and ask personally that patient about the NPO status, since how long he has not taken. That is also important, because many times the pressure might be purely under local anesthesia, but suddenly patient become irritable, they request you to give sedation, patients don't get sedated, you increase the depth of sedation and patient suddenly vomits and aspiration occurs. So you must check all these things when you go to the cath lab. Now, monitoring, by protocol, they put all the monitors to the patient, but you must ensure that ECG is put, SpO2. In some cath labs, SpO2 is not attached. You must attach SpO2. Then arterial line is there for the procedure, and in between, we get a blood pressure reading from that. Apart from that, coagulation monitoring, because these patients, we give heparin, and if there is a ACT machine inside the OT or inside the cath lab, it is always desirable. We want to keep ACT around 250 to 300. Another important thing is temperature. When there is a prolonged procedure for cath lab gantry, to keep it cool, the temperature of cath lab is very low, even as compared to OT. So there are high chances that this patient will go in hypothermia. So we must keep very close watch on temperature, and particularly for prolonged procedure. Nowadays, we are doing almost 3 hours procedure, 4 hours procedure in cath lab, and patient becomes so much of hypothermia. So we must keep watch on the temperature of the patient. We must ensure adequate length of cables, IV extension and circuit. It is for doing ease, for our work with ease, and these are a basic requirement from our side. Longer bench circuit, longer IV extension help us to manage pressure bit on through remote, slightly on a remote place. So it is very, very important to ensure these extended cables, IV extension and circuits. Now, what are the common complications? There will be a complications, and we have to deal with that. There is no other options. But commonly there will be, while stenting, while balloon occlusion, there will be STT changes. If it is settled down after depletion, it is well and good. But if it won't settle, then one has to take actively, because we have to increase the blood pressure. Maybe we have to increase the oxygenation. We have to give nitrates. All these things we have to do. Hypotension is very, very common, and all inotropes must be kept ready, maybe noradrenaline, maybe mephenteramine, all drugs we have to use during this period. Arrhythmias, all sort of arrhythmias you will be able to see when you start working in cath lab, right from barrier arrhythmias to supraventricular tachycardia to ventricular fibrillation, and they are very, very common, and you should be well versed with managing all those arrhythmias. And once you start attending those calls over a period of time, you will realize how to manage these arrhythmias. Then air embolism. I have seen so many patients, means from operator might inject suddenly air into the coronaries and patient's heart gets stunned. There will be a hypotension, patient become restless. So this is a very, very common complication, and you have to be extremely alert in whenever such things happen, and you have to treat these patients very, very aggressively. Another unnoticed complication is blood loss, because we are standing away from the patients and whole cath lab team is working, but unknowing lot of blood loss occurs and a patient may go in a shock after the procedure. So we must keep watch on blood loss. Not only that, puncture site blood loss is where everyone is busy looking at the heart, but unfortunately at the femoral side there will be a huge hematoma. So we must be, additionally, we must keep our eye on this blood loss. This is very important. Patients become anxious, irritable patients, suddenly you have to give sedations. These are the very, very common complications that you face in day in and day out when you are working in a cath lab. Now, some of the rare complications like local anesthesia toxicity, suddenly they start giving local and patients start convulsing. This is relatively, though rare complication, but I have seen it many times, and you have to immediately act on it. You have to immediately sedate the patient, give midazolam, diazepam, whatever drugs are there, and take all necessary precautions to avoid further damage. Tamponade regurgitation is also very common. We have done 2 or 3 tamponades which occurred in a cath lab, and we have to take these patients many times straight away into the cardiac theater to deal with these sort of complications, similar like a ventricular rupture device misplacement. These patients requires immediate action, and surgeon is involved and patient is shifted into cardiac OT. It itself is a very challenging shifting such patient who is very sick, who is hemodynamically unstable. And for this, we must call for help. We take the help of our colleagues. We must involve many people. We have to act very fast. Maybe blood pressure is not there at that time. You have to put the lines and start giving anesthesia, put them on pump and all things. But we have to do it when such complications are. Similarly, patients of congenital heart may suddenly go in cyanotic spell or anaphylactic reactions to the contrast. These are also very, very common. And let me tell you that I have, not only me, those who are working in cath lab from years together, maybe Sujit, Pramod, and all those, even Deepak, everyone has seen all these complications. But the good thing that I wanted to reassure you that is, I have personally seen surviving patient from all these complications. I have seen so many patients of tamponade are discharged, or even a patient of ventricular rupture. Pramod has done one case, and even device misplacement. So the complications, rare complications, are very devastating, very dangerous. But if you act fast, if you work as a team, if you take the proper help, and you can definitely, patient can survive from all these complications. Now, many times we called in cath lab just to give sedation. And for that, first thing, you must counsel this patient. You must tell that patients you will have a minimum discomfort, but we will give you some injections that will nullify your pain or it will minimize your pain. So counseling whenever you are giving sedation to the patient is very, very important. And it's very tricky to give sedation in this patient because if you give too much sedation, patient will desaturate, patient's breathing pattern change, which is disturbing to the operator. And if you give too less sedation, operator says, oh, you don't have given sedation. And unfortunately, cath lab people, when they say sedation, they think that it is like a GA, means once you have given a small sedation, patient will be like under GA, he won't respond. But this is not like that. So you have to give it very slowly, gradually, just give small, see the effect. And if very small dose of sedation, also some patients get sedated. So you have to titrate the dose as per the patient. This is very, very important. Adequate local, this is very, very important. Whenever, particularly in pediatric patients, I personally try to give the local at femoral, and then I give sedation or small dose of ketamine propofol, and then I personally try to give the local at the femoral. Adequate local can decrease your sedation dose. This is very crucial. So I always ensure that adequate local should be given, and you can request operator to give adequate local at local site, or you yourself can give. Then keeping warm blanket, warming eye fluid is very important, particularly when patients are in sedation. Suddenly the patient starts shivering and operator say, oh, stop shivering, he's disturbing me. So it's a very difficult situation for us. We have to give more sedation, and for that, it is better to prevent shivering. And once you can able to prevent shivering, the dose of sedation is also less. So you should always take a preemptive step to avoid the complications. Many times we have to electively give GA to so many conditions in cath lab. We must take informed consent for that patients, like conditions like AICD, automatic implantable cardiac defibrillator, transcatheter aortic wall replacement or implantation. This patient, we have to electively ventilate the patient, put endotracheal tube, because many times we have to do TE, but last 3 or 4 cases of TAVI, we have just given a sedation, not general anesthesia. But these modifications we have to done after a discussion with that cardiologist, and we have to modify our technique accordingly. Invariably, workstation is not available in the cath lab, so we have to rely on ventilator, ICU ventilators, and if we are using ICU ventilator, the choice of anesthesia invariably is a TIVA. It is better to put on infusion pump combination, maybe of propofol plus maybe midazolam or ketamine or dexmedetomidine. It is as per your choices. You can take the help of TIVA while giving general anesthesia to these patients. Intubations versus laryngeal mask, it is your personal choice. But I think if patient is hemodynamically unstable and patient is likely to go in hemodynamic instability, it is better to intubate these patients. But certain patients, pediatric patients, where you don't expect a lot of hemodynamic instability, laryngeal mask can be tried. For all prolonged cases, fortunately, already arterial line is in situ. You must ask for ABG to correct all metabolic derangement, and in a better way you can manage the patient. And for all congenital heart disease patient, you must keep a very strict watch about dearing, because these chances of paradoxical embolus are very high due to the opening in the septum. When you are taking care of the patient, you yourself has to take care of yourself also, because you are exposing yourself to a radiation. For that, you must understand that you must wear all lead apron, thyroid shield, if available, eye protection, all those. Dosimeters for cumulative exposure tracing is advisable, but to most of us, including me, we don't use, but ideally it should be 2 badges should be used. One is inside under the lead apron and second on the collar, and repeatedly dose how much dose we are receiving of radiation, that we must calculate, and we must take actions. Or if there is excessive radiation, we must avoid cath lab for few days. This is in ideal condition, but unfortunately this is not followed. Then important is to understand is the source of radiation is this X-ray tube. And invariably many times we have confusion. We have to stand away from this tube. This is an image intensifier. This is a radiation generator, X-ray tube. So distance from the source of radiation is very, very important, and intensity of radiation is proportional to the square root of distance away from the exposure. If you are standing just near to this X-ray tube, you will get the maximum radiation. As you go away from this, you will get a less radiation. But unfortunately, anesthesiologists many times stand here and he get the maximum radiation. So whenever you get a chance, you should stand away from this X-ray tube. More than, if you stand more than 80 centimeter, means almost 1.5 feet, almost radiation dose is reduced by quarter. And if you stand almost more than 4 feet or 5 feet, the radiation dose is very, very minimal. So if patient is stable, you can go towards the leg end of the patient, and there you can monitor, you can watch the cath lab unit and all, even the patient. So I think that is the better place, avoid the radiation. And this ALARA principle they are using means as low as reasonably achievable, but this is not in our hand. It totally depends on operator, how much radiation he is giving to the patient and he is taking himself. So, and many operators take too much prolonged time in the cath lab, which are adding additional burden on all cath lab personnel, including themselves. But unfortunately, this is not in our hand, but we can request them to minimize the radiation. Now, there are so many other occupational hazards when you are working in a cath lab, like neck and shoulder stiffness due to these heavy gowns. Then it is continuously standing. There are high chance of varicosity, low back pain, muscle fatigue, even edema feet. For that, there is no other option but to stretching exercises, neck, shoulder standing, stalking, walking, and you have to keep yourself fit for all these demanding procedures. So daily yoga, daily exercise is must as an anesthesiologist to avoid such kind of complications. What are the clinical pros? Over a period of time, I realized that certain things, if you do, it increases the safety of the patients, or it increases even your experience as an anesthesiologist during the procedure. So experience is not what happens to a man, but it is what a man does with what happens to him over a period of time. I realized certain things that I wanted to share with you. And whenever you enter into the cath lab, always ensure that you check anesthesia equipment, whether even red, it may be like ambu bag also, or bench circuit also, and check whether that is proper, there is no leak, the bag is present, you can give oxygen, oxygenate the patient immediately. Always check defibrillator. There is a protocol in certain cath lab, they will check the defibrillator every day, but you just ask whether they have checked it or not. Always ensure availability of drug. Not only availability of drug, I am always comfortable when certain drugs are loaded, particularly mephenteramine, particularly low dose adrenaline and atropine. If these 2 or 3 drugs are ready, and availability of cardaron, potassium, magnesium, if they are available inside the cath lab, your life becomes a bit easy whenever emergency comes. Always check NPO status. Patient is not NBM, and if you need to give sedation, then you can ask that fellow, I cannot give too much sedation. That is very, very important. So always check on the patient rather than just going and giving sedation, and patient is NBM, not NBM, then it's a very huge risk as an anesthesiologist for us. So you must check this. Then I try to personally check IV access whenever I go inside the cath lab. This I already mentioned in my previous slide. This is very, very important because something goes wrong and IV is not properly inside, you are in the soup. Always take extra large bore IV access. If you feel hemodynamic instability is going to come, if you feel this is a very high risk procedure, there is no harm in taking extra large bore IV access because it will help you for inotropes. It will help you to fluid resuscitation. It will help you to give drugs fast in a hurry or in a fast manner. So you must take some preemptive actions. Always ensure that all antiarrhythmics are ready. Always ensure that adequate warm fluids are there. So these preemptive actions can probably prevent the complication. That is very, very important, and try to be perfect in advanced cardiac life support. You must, after 1 or 2 months or every 6 monthly, try to go with those algorithms. They are changing every 6 monthly or 1 year, and we must be well versed with this advanced cardiac life support. That is what is required in cath lab whenever there is an emergency. GA to all very high risk patients. If suppose if a patient is very hemodynamically unstable, he is not likely to go in a very hemodynamic instability. It is better to intubate these patients and do the things properly rather than intubating this patient in emergency, because in emergency when you go for intubation there are high chance of complication. So always give general anesthesia. If patient is very high risk, just convince that I will give GA, and if you convince the cardiologist, he will also agree with your suggestions. Then if patient is very high risk, then going in a very hemodynamic instability, you just put CVP and keep inotropes attached. This is a very important step to avoid further complications. If there is a bradyarrest, patient is convulsing. In that convulsion, it is very difficult to take the femoral access of this patient. But if transcutaneous pacing is available, as soon as you pace the patient, patient becomes calm. So such things are very, very important. And for that matter, you must know that how to do transcutaneous pacing, whether that cable is available inside the cath lab, that machine, is it adaptable, or machine do provide this facility of transcutaneous pacing. So you must prepare with this. And for that, you have to take a preemptive actions. If there is a witnessed arrest, be very aggressive. This arrest must be revived. This is what I feel, because all witnessed arrest can be revived if you take a proper protocol, or if you take a proper precautions, or if you aggressively manage them. And at least very rarely I have seen witness arrest which is not unable to revive. So if there is arrest, maybe due to air embolism, suppose there is stunning of myocardium, it will take a lot of time to revive this arrest, but it will get revived. So you have to be super aggressive. You call for help. You take the help of your 2-3 colleagues. You take the help of cardiologists. You take the help of intensivists, but try to manage this arrest very aggressively. Then for high risk cases, when you are in doubt, when you are not getting any clue what's happening, it is better to put transesophageal echocardiography or transthoracic echo or focus of this, what's going on. And it really helps you in further navigating these patients. And keeping cardiac OT or surgeon, sorry for this spelling mistake, surgeon on standby is very, very important. Invariably, cardiologist will do it, but you must also ensure, suppose there is a transcatheter aortic wall replacement or implantation is going on, this cardiac OT and surgeon must be ready. So this will keep, suppose there occurs a sudden emergency, and if it is not ready, then you are just get stuck and you cannot do anything for this patient. So these are the very small tips, but they are really help us and in averting major complications. So this good decisions comes from experience, but unfortunately experience come from making bad decisions. So rather than making bad decision and taking experience, just try better to make good decisions with experience of others, not that you should all face this and then make good decisions. Rather, if you take preemptive things, then definitely you can avoid all these things. In conclusion, I think anesthesiologist is now become an integral part of interventional team. And his responsibility is not only for anesthesia, hemodynamic and ventilatory support to the patient, but is also for echocardiography guidance of the procedure. So our role in cath lab is very, very vital. And if you go with systematically, if we go with proper knowledge and proper preparation, I think we can handle these emergencies in a better way. Thank you very much.